And today, okay, that recording always throws me off. Today I'm going to be talking about, from our survey, everybody wanted to see some information on treatment planning. And I found this as really interesting. So treatment planning is not, it's not like one of my passions that I like to talk about. However, treatment planning is really interesting. And I do a lot of treatment planning work with supervisees. And one of the things that I have found is that it's really a necessary step, and treatment planning is very different. And through this process, actually, in getting ready to present, I started looking through a lot of the literature. So today I'll be presenting on some of the literature that I found, but also more of what I've learned over the years in treatment planning. Because when I look at the literature, there's not a whole lot on treatment planning. So I don't know if any of you went to look at it, but there is. So treatment planning, you have to take a couple things into consideration in regard when looking at treatment planning. There is specific literature and specific ways to treatment plan around specific diagnoses. So depending on your diagnoses, sometimes there's specifics, but for those of us who work with children and families, and I'll touch some on that, diagnoses are all over the place. And for those of you who are generalists, diagnoses are all over the place. So you're not always working with one specific population. Treatment planning also can be specific and specialized, especially around, programming, what type of program you're in and the requirements around that. And also, unfortunately, sometimes insurances guide our treatment planning, right? We have to have certain information and certain goals that we have to meet for specific individuals. This can be a struggle. It's a struggle for me. I have, I see a couple patients with Down syndrome, and every year I get the insurance company requesting their treatment goals, and I get told that I'm not treating the Down syndrome. And so I'm like, you don't treat the Down syndrome, right? You treat the symptoms. So I just had to reword some of it, but it's so frustrating when you come around that. So when looking at a good treatment plan, what do you want it to include? Or what does a good treatment plan do? It improves the quality, safety, efficiency of what you're providing. We're talking about mental health treatment plans, right? And mental health treatment plans, when we're following them according to the intake and the diagnoses that we're treating, we reduce health disparities because we know that it's mind and body, right? So not just the mind, not just the body, but mind and body. So we know that when we're effectively treating mental health, that we do reduce some of those health disparities. Especially when working with families, you want to make sure that you're engaging the patient and the families. So that is really good to do with treatment plans. And then improving care coordination. We want to make sure a good treatment plan is not going to duplicate services. And many of the times our families have so many providers that we want to make sure that we're coordinating care and opening up. I think that's really hard, especially, in the outpatient. Well, I'm sure in all programs, but in outpatient, it's really hard, right? It's hard to follow up with. It's hard to just continue to coordinate care between. But once you got a good rhythm and you can coordinate care, it's most efficient for that person, child, family all together. So coordinating care is really important. Good treatment plans really involve, you identify the problem, right? So for treatment planning, you're identifying the presenting problem. What is it we're addressing? You utilize screens, so some screening tools that kind of help you measure where that problem is, so that once you start that treatment, you can rescreen and identify if the problem is decreasing, increasing, or remaining the same. If it's increasing and it's a problematic behavior, then absolutely you want to look at a different type of treatment approach. So screens are really beneficial in that way and helping you measure that. Family reports, you want to make sure that you're taking everybody's report, especially when doing family work, right? You want to make sure that you're involving everybody's information and taking everybody's report and making sure that you're developing that therapeutic relationship. That is key for treatment planning, and that is key for treatment altogether. One of the things that I talk about when working with supervisees is, if they come across their treatment planning, if they're struggling with a family in treatment, we always go over the treatment plan, right? Like, what are your goals? Where are you at? What's the screening measure? Like, how far have they come? And when we look at that and they're like, we've had this goal forever, and, I just can't get them past this. And so we talk about that, right? It's not really up to them to get them past it. We're just here to facilitate through that. But we always come back to the therapeutic relationship. Like, is there a therapeutic relationship? Sometimes something's happened over time where that has fallen apart or kind of disconnected. So we always rejoin at the therapeutic relationship. If you don't have that therapeutic relationship, you're not going to get anywhere in treatment. So that's really important. And then we also pull from the hypothesis. So, working with families, we come from a strength-based approach. We pull from a hypothesis. And so you want to make sure that your hypothesis is a strength-based hypothesis. And you can create treatment goals and objectives straight from your hypothesis. You want to make sure that it's a hypothesis that your family also buys into. So it shouldn't be just your hypothesis, but you should be able to share this with your families so that they buy into it and you can utilize that with them too. You can use this for individuals too. It's only because I do some family work with it that I use it. But so for example, and I just taught this, so it's like fresh in my mind, this role play, right? So for example, let's say I have an 11-year-old child that's brought in. Families in conflict, mom and dad have divorced. It's been a year. They both have remarried within that year, right? There's 2 other siblings involved in this family, and they really brought her in because she's having high anxiety. So dad had brought her in and was interested in possibly family therapy or individual therapy. So from kind of talking with them and talking and identifying the conflict that's in the different relationships, but especially between mom and dad. So lots of conflict between mom and dad, parenting styles, their visitation. But the problem that they're identifying, their presenting problem, is the truancy. So they're saying that her high anxiety is creating her to not want to attend school and creating truancy issues. But after the first meeting and seeing all of the conflict within the family, the hypothesis that the team came up with was that if we reduce the conflict within the home, then the child's anxiety will reduce, right? And so, or one of the other hypotheses to stay strength-based was if we increase positive communication amongst the parental unit, then the child's anxiety will reduce, right? And so you can see just from that hypothesis and from our assessment and seeing that and creating that hypothesis, getting the family to buy in, right? Saying, well, okay, so this is what we've talked about. This is kind of what we're seeing. What do you guys think? Now, sometimes you get people in families who are like, nope, that's not what's going on. But sometimes you get people in families who are like, yeah, absolutely, I could see that. But if you think about it as a provider, you could have so many goals from that, and you can pull up so many objectives from that. You can go in many different areas. So it's structured, but it's still vague enough to allow the family to interpret and utilize some of their own goals and for us to go in a direction. But with that hypothesis, at least we're kind of addressing what we're seeing, and we're not necessarily creating the goals, but we're kind of giving like an open canvas for families to create those goals. So I love using a hypothesis. Treatment plans include the defining problems. So we talked about the problem, a timeline for treatment progress. We want to make sure that they're measurable, right? Major treatment goals. So we can have short-term treatment goals and long-term treatment goals in treatments plans. Milestones, where they're hitting them, the tasks, specific tasks and objectives. So this is a really important piece to utilize too, and to identify like what you want to use for your specific measurable tasks and objectives. You want to make sure it's measurable. The reality is if it's not measurable, then we're not going to be able to identify if they're making any progress or not. And so how we kind of make it measurable is we assess where they're at currently. So if you're not even using a screening tool, just kind of saying like, if someone comes in and says, okay, like little Johnny's having temper tantrums every day. Okay, how many a day do you think he's having? He's having like at least 6 temper tantrums for an hour and a half long every day. So if we go for a behavioral approach and we make a treatment goal around that, we want to reduce those tantrums to what we feel like the family would be capable of managing, right? So maybe this family will start off like, okay, so we want to reduce the temper tantrums to 3 times a day, right? That's a big jump, but that's half. So if we think that it's a really motivated family and they can do that, then absolutely. If this family is like not really motivated, not really engaged, okay, so let's reduce it to 5 a week or a day. But at least you have that measurable piece, and then you're coming back and kind of reevaluating it. So you're holding them accountable. You're holding yourself accountable for providing the appropriate treatment, but it's also measurable. I don't know. When I supervise, I always use measurables as in numbers and not percentages. Like sometimes people say like 80% of the time or 90% of the time. Insurance companies don't like percentages. They have a really difficult time with that. And so just being careful with your percentages. Developing SMART goals. So we all know what SMART goals are. And so we can utilize this when we're developing goals for treatment plans. We want to make sure they're very specific and measurable, right? Obtainable. So we talked about all 3 of these. Attainable being something that this family can achieve or this individual can achieve. We want it to be realistic and time limited. So we want to give them a specific time that they would achieve this by. So if we're reducing tantrums, with little Johnny, I typically give them about 2 weeks, right? We want to see, because behavioral changes a lot of the times can occur within 2 weeks if we're consistent. And so we see at least some change. So if we don't see any change, especially if we're doing a small, like it was like a small measurable, like from 6 to 5 a day, let's reevaluate this in 2 weeks. And so we kind of look at when we're going to reevaluate it, again, holding us accountable and holding our families accountable. So it's almost like a contract, right, for our families. Make sure you include patient statements. So always use the family language in their statements. If they say something, I mean, we try to stay strength-based. So if they say it negatively, we try to reframe it to a strength-based kind of thing, or we ask them to think about it. Like, let's think about that in more of a positive, how can we say that in a more positive way? And getting them to start thinking that way is really beneficial. So having them come up with that themselves is great. Using their own language and statements gives them ownership of it. And so they're more likely to follow through. Providing their personal perspectives, like what they think, what each family member thinks. So if you're doing family therapy, looking at what each family member thinks of these goals and what they think they'll be able to achieve, and what are some barriers you might come across. Exploring barriers probably could be a whole session within itself, but really starting to kind of explore some of that. Of course, include some of your psychosocial history, your diagnosis, again, your measurable objectives, and prioritize treatment goals, right? What's most important? We don't want to have too many treatment goals. When I work with families, children and families, I usually only have 3. I usually only work with them having 3 because it's a lot. It's a lot, especially if you have several objectives under each goal. I think I just did family therapy 2 months ago with this family, and we were working on goals and treatment planning. And this family had so many goals. I had to like really prioritize and get them to kind of pull away from some of the goals and really identify like what's really important to you and your family right now. Let's hold these goals. Let's put these goals on a back burner, right? So we didn't get rid of them. We heard them that they want to achieve some of that, but we kind of put it on the back burner because I think mom had like 5 objectives with the 3 main goals that we put out there. And so we really narrowed down some of those objectives and kept the 3 goals. So needed to determine appropriate treatment planning, we need to get, just like with your intake information, right? This is where we determine our treatment plan by getting some of the history, demographics, assessment, diagnosis, what the presenting problem is, what the family strengths are, or what the individual strengths are, right? This is really important to kind of phrase things like, what have you been good at? What have you been successful with? When you're working with individuals and they're trying to really start to work on themselves and their self-esteem, like, what have you been great at? people are trying to like get to work and figure out how to be an accomplished individual, and then explore that, like, what is your greatest what is your greatest achievement in life, and kind of asking some of those strengths-based questions so that you're really gaining a positive perspective. When I work with families, I always ask, like, what are families supposed to look like, right? Like, I'll ask the kids, what are mom and dad's or what are parents supposed to look like? And then I ask the parents, like, what are kids supposed to look like? What are they supposed to do? This kind of helps give you some of their belief system and start to identify that along with some of their strengths. Like, what do you all do well as a family? And so really trying to show them there are some positives. Many of the times families are there for something that they're struggling with. And so it's really hard to see some of those. And as we utilize strength-based approaches in family therapy, we really want to start reframing that from the beginning. So starting to kind of point some of that out. Then, of course, our treatment goals and our objectives, you'll see the repeat of that because that's number one, right? But treatment plans are roadmaps for treatment. Again, this kind of helps us identify where we're going. It helps our families identify where we're going. I will tell you that when I don't do a treatment plan, because, sometimes we're in a medical setting, we're not always required to provide treatment plans, but I mean, everybody kind of does to utilize that as a roadmap. But if I forget to do a treatment plan, it's like, where am I going? Like, what were my goals? Like, we're going to put them down. Like, and so if I'm confused and lost, guess what my family is? Confused and lost, right? So we need that roadmap. It's a parallel process. We have to follow it as much as them. You should be reviewing your treatment plans. Again, it really is specific towards your program and what your requirements are, but at least every 30 days, you should be reviewing that to kind of see where you're at if your goals are not sooner. Treatment plans really help reduce risks. You'll see more effective treatment with treatment plans. It really improves outcomes, right? You have better outcomes when you have those treatment plans. It's a trauma-informed approach, right? Everybody likes to know where they're going and what they're doing and what they're working on. And so this is really beneficial. We just learned in our electronic records that we can now print this out. So this is nice, like for our patients, like treatment plans, so that we can give it to them. It's always nice because I write mine down and give it to them, because when you document it in electronic records, it's not always theirs. And so I like to have it as theirs. I usually do, especially when I'm doing family therapy, we usually do it as an activity altogether. And so I give that paper to families after I document it. Treatment plans serve as structure and purpose, right? It should be shared amongst one another. It should be positive. Again, using the individual or family's language, because they'll buy in more. You want to involve all members. Now, this is really hard, but I have to tell you, I had a family one time I worked with, and there was a lot of, it was a 13-year-old, 11-year-old, and a 5-year-old, and the parents, and really, there was a lot of problematic behaviors with the 13-year-old and the 11-year-old that was creating a lot of conflict amongst the entire family. Really not so much the 5-year-old, but the 5-year-old was included. And when I didn't use some of the 5-year-old's goals, like one of the goals that really weren't relevant to anything, they had a really hard time with it. And I realized, like, this is important. We have to involve all family members and make sure that they feel involved. And actually, some of the 5-year-old's point of view and perspective really helped the 13-year-old in treatment to see how their younger sibling was perceiving some things. And so you have to take that into consideration, even if it doesn't seem like the goal that the 5-year-old wanted was really way in left field, but that's okay. We could have created it around or had something around that. But it improves communication, right, amongst families, overcome relationship problems and cultural barriers. Barriers to effective treatment planning is confidentiality, of course, just remaining confidential. It becomes really tricky with families, right? Especially because, you have to, I was just teaching a class about this, but you have to be careful. You have to be careful what you're documenting and how you're billing. And what you're sharing. And in family therapy, especially if you're doing a systems approach, so if you're working with each system and you have different subsystems that you're working with, you could be working with the parental subsystem, you could be working with the sibling subsystem. You have to be very careful, because what can happen is you can unintentionally share some of that information in one of the other systems. So you have to be very, very careful that you're confidential with all of those systems. But also, you want to make sure that you're billing. In outpatient, I almost have to open up under all of the individuals I'm working with, or at least all of the systems, right? So let's go back to the whole 11-year-old, right? That we developed the hypothesis around. Mom and dad remarried. So I had to open up under mom, dad, and the 11-year-old. So I could bill in outpatient under the 11-year-old and any of her siblings. So I can do a sibling subsystem there. I could also bill for family therapy with her. I could do that with mom and maybe her significant other, or mom and dad, or maybe all four of them, mom, dad, and both significant others, right? So you have to be creative with that and make sure that you're doing it appropriately. And it can get really tricky, but you have to also be careful with confidentiality too. So in what you document. One of my family therapy cases, and not to scare anybody, but this is the reality, is one of my family therapy cases went to court. And being that they were 12 years old, the parents could pull all of their documentation and look at them, right? And if it's family therapy and you're documenting some of the other individual stuff in that chart, it can be really tricky. So you have to be, you shouldn't be doing that. You need to open up under other individuals so that they're not able to pull that. But yeah. Other barriers could be alliances, right? So if there's alliances with two individuals against another, I had a family one time where the sibling subsystem had an alliance, and it was a total barrier to treatment. So it was the oldest sibling and the two siblings, they followed him naturally, but they followed his lead, and they all three had an alliance together. And they were not sharing or engaging very well. And then the oldest one really started to engage, and he would put little feelers out there, little things he would say to me to see if I would break confidentiality and tell the parents. And when he realized I didn't, he told, we had a sibling session, and I'll never forget when we were sitting there, and I was like, okay. So it was like pulling teeth to get them to participate. And he finally turned to them and he said, listen, she's not going to tell mom. I tried it. And so then they all opened up, and I was like, this is fantastic. But those alliances can really be barriers sometimes. Using unrelatable language, having judgment, any type of judgment, we know that shuts people down. And again, not involving all members. Some treatment areas that you can look at, especially when working with kids: ADHD, conduct disorder, depression, anxiety, trauma. These are my common ones. So I went back and looked at my common ones, but this is not limited to this, right? We know that we treat other areas. And the most common treatment goal topics that I've come across are academic, anger, body image, right? Disruptive behaviors like number one, and family conflict, impulsivity, and lying. So those are a lot of the treatment goals. And when I work with families, I try to have just those three. So usually it's an individual that's being brought in when we do family therapy. Like I said, like the 11-year-old, right? Like she's having truancy problems. I think they're stemming from her anxiety. And so the family talks about it. So we have an individual goal, right? So that we're naturally working in this parallel process that while we're addressing, so it's the content versus the process, right? The process is what's going on with the family underneath the hypothesis that we talked about. And then the content is, the behavior that's kind of surfaced from this, and that's her anxiety. And so her individual goals would be around her anxiety. We would want to work and help her anxiety while we work on some of this family therapy stuff, so that she's learning how to cope with that as we're dealing with some of the process. So we're addressing the content and the process. And then we develop family goals depending on what the family wants to do. And I always include a community goal. If you think back to some of these areas, right? Anger, there's usually anger outbursts within the community, disruptive behaviors in the community, right? Impulsivity, lying. So in public places, in school, in extracurricular activities. So we always develop goals around that, right? To help increase some of their functionality in those areas too. Goals used with kids. So when I'm working with kids, a lot of the times I have goals. I try to formulate goals around their cognitive thinking. So their ability to think and how they're managing that, their relationships, like, is this relationship based? Working on friendships, relationships within their family system, whatever it might be, competency. So their competency levels on handling these things, and brain-based learning. So how are they using their brain? Are they using their lizard brain, or are they using their wizard brain, and how can we help that? And so usually I try to formulate goals around these areas depending on what their presenting problem is. So depending on what their presenting problem is, what they've already worked on, what they want to work on. And so really it depends on what they want to work on to where I formulate in which area. But this is an example of this is just an example of a goal. So like if I had a kid with ADHD, and let's say the goal is to improve concentration, the parent's like, I really need them to concentrate. Like Johnny really needs to start focusing in school. So Johnny will examine inattention 2 days a week by what? So you use their specific strengths here. So how's he going to increase that? And so we really explore with him, and they're not going to know, like they're not going to be able to tell you this, but we talk to them about it. Like, how do you think you can pay attention? What would help you focus? And so we try a couple different things. And if it's not working, we come back to it and we change it. And that's the whole purpose of the goal, right? This is a goal. We're exploring and utilizing some of those tools in our tool belt. And if they're not working, then you get a different tool. And so we just we use this to kind of explore that. And then I can't see my second goal because my line's there, but impulse control. So Johnny will explore their external and internal distractions by attending weekly, right? And so then your goal is to explore some of those distractions. So, what's distracting you? So, internally, what's going on with you, and externally, what's going on with you. And so there's a couple activities I actually do around that one. And that actually, I will say that this goal takes quite a few sessions to really explore this. And there's a lot of different activities that can start to identify it, but then you work on it, right? So you can even move towards a goal of them controlling an internal distraction, or how to avoid external distractions, but just identifying it and becoming aware of it takes some time within itself. And so you can see how goals are meant to change, right, throughout. So once they achieve goals, you want to move forward and change them. So even if you're not reviewing it until 30 days, you still want to kind of go there and change it if they've achieved a goal. Other example of goal topics that I've utilized a lot are pro-social behaviors, right? Boundaries, being a good friend, what that means, what that's like. So many kids are having a hard time with socialization right now. And so we talk about that. And a lot of the times kids, especially with ADHD, they have a hard time making friendships and holding friendships. And so we talk about that. Time management is another one that really goes across a lot of those diagnoses. Self-regulation, stopping and thinking, right? So this kind of goes under that brain-based goal system that we talk about. Whole body games. So talking about how, we can talk about diagnoses and how it impacts the whole body and what that's like, and becoming just aware of that. Or like with anger, anger you feel physically first. And a lot of the times with kids, that's where we start with our goals, is just kind of identifying that physical response so that they can start to identify when their anger is building. Healthy habits. So exercise, sleeping, meals, right? This is really important, especially, we usually have a sleeping goal and meal goal for little ones when I work with 5 and under specifically, but sleeping and meals are huge for them, have a huge impact on their ability to self-regulate in their mood. And so we always usually have goals around that. Positive thinking and having a positive mind. So journaling or whatever we need to do around that. And then this is it. So acknowledging your small victories that will eventually add up to something great, right? I always say that with families, and especially, kids and individuals too. small steps, right? Acknowledging those small victories. I know some people want big change, but sometimes just those little pieces and those small victories, it's the small little battles that win the war. And that's what I always tell families, like the small battles win the war. You sometimes lose some of those battles, but it doesn't mean that the war's over. And so we talk about that and explore that through treatment planning. So any questions, thoughts?
Thank you so very much, Amanda. That was excellent. That was such a great job. Teresa said that is so true about sleeping. I firmly believe that everyone gets more sleep, the world would be a nicer place. Oh yeah, including myself. If I'm hungry or I'm tired.
Yeah, so that's what I say, right? The halt is something that we always explore. If your kid is hungry, angry, lonely, or tired, right, then chances are they're going to have some behaviors or dysregulation or something going on. And I love, like, I have to say, like, I love talking about things like treatment plans. And sometimes we all learn this, right? Like, we all learn this. We all know this. We all know that this is something we have to do. But sometimes it's a real good reminder to stay on top of it, because we get busy and we get away from it. And sometimes it loses its value for us. And so I just feel like it always kind of replenishes me to be more aware of how valuable treatment plans are when I do stuff like this.
Amanda, that was wonderful. You said something I wanted to pull out of there, because I've never heard you say this before, and it sounded so cool, about the lizard brain and the wizard brain. I thought that was so creative. Could you elaborate on that a little bit to make sure I know how you're using it right? Because I just love that. I want to hear more about that.
Yes. So the wizard brain is our functional brain. So like my hand model that I always go over, right? So the top, your decision making, is your wizard brain. The bottom is your emotional piece. It's your lizard brain. So when kids respond emotionally, and they become dysregulated, right? Then they flip their lids. So I think everybody has seen me do the flip the lid model, but when your brain flips lid, you no longer have that decision-making piece there. And so we need to calm kids down before they can make any decisions with that. So we talk about that being the wizard part of our brain. So let's use the wizard part of our brain. And we talk about exercise, like for the older kids, we talk about exercising that part. So like, we want to use more of our wizard brain, or what were you using in that? Like, so if parents will always come in and report like what happened, like a bad moment, or, just some behaviors. And I'll say, so what do you think you were using then, your wizard brain or your lizard brain? And kids love it that way. They're like, oh, I was using my wizard brain. I want to use my wizard brain. So they really like that piece. And there's so many, like, if you just even Google, there's so many activities and coloring things around. It's fun.
That's excellent. Thank you so much. And thank you, Dr. Swagger. Does anybody else have any examples or what their methods are, or, those little like cute things to make you remember the lizard wizard or anything like that they'd like to share with the group? Dr. Swagger.
Sorry. I really love the point about when you were talking about family related goals and kind of having a piece of the pie for everybody, so that everyone really feels like a stakeholder, no matter how young they might be, or how, related it might seem to our traditional, therapeutic structure. I think that's just such a wonderful, important part. And I think, one thing that's been really helpful to me in building rapport and trying to figure out what are meaningful goals for families at outset is just asking them for a little bit, like, can you just paint me a picture of what is a good outcome of our time together, working together, look like? Can you show them, like, maybe that's in the form of like being able to go out to dinner someplace and not being worried about a meltdown, or being able to have, a mom and dad date, once a month or something like that. And then, again, just to give that opportunity to the kiddos in the household as well. I think it's really wonderful. So glad you touched on it.
Yeah, absolutely. I love that. I love the painting the picture of where they want to be and what they want to do. I think that's a great motivator too, and to hold them accountable.
Well, and I just wanted to add, I know this wasn't focused on medicine, but I think for those people on here that do prescribe medicine or involved with medicine, I think it's important to set like clear treatment goals for the medicine and relatable behaviors too. It's recalling, like, even for ADHD, like the expectation that if my kid's on medicine, they're going to listen to everything I say, or the behaviors are going to get better, and how that's not accurate, and that we need to set some more like concrete expectations about it. It's going to help with this, but it's not going to do that part, and taking some of those treatment planning specific things and setting those expectations for the medication part of maybe their treatment as well. So this was a reminder to me about how important it is to do that with medicine, which I actually don't always think we do a very good job at thinking about it that way. But I think that was really helpful for me.
Yeah.
Thank you. Any other comments or suggestions? And it could be related to something else too. We do have time. If anybody has any, cases or questions or opinions needed.
Well, you were just asking how we were going to remember this, so I wrote it down on a Post-it. I'm going to stick it up somewhere along with Powers, Robots, and Jellyfish for mindfulness practice with kids. Again, those both sound like just wonderful ways of engaging young minds.
Robots
and those young at heart.
Yeah, I like that. I like all that stuff. I'm a kid at heart, though, so this might work for me. Excellent. Well, if there aren't any other questions, or if they do come by, please shoot them our way. Me, myself, and Jay are going to be out for a conference on the next supposed schedule for our November 16th, so that'll have to be canceled. I apologize for that. So the next time we will meet will be in December, which is crazy, December 7th, and Dr. Swagger is going to be discussing pharmacology and tobacco and vaping use. So until then, I hope you guys have a great holiday. Please reach out if you need anything, and we'll be around. Thank you so much.